Uh-oh, I lost you. Lisa? Uh-oh. Lost you. Lost you. All right, I lost. You're there now? Can't hear you.
I had a little glitch with my computer there. Sorry, guys. Hi, I think we're live. I don't know what happened. Technology doesn't want to be my friend today. Good morning, everybody. It's Lisa Salberg, and we are here, I hope, live with you on Facebook, recording Tales from the Heart. Yep, that looks like we're good. Oh, it's going to be one of those days, people. It's going to be one of those days. So, number one, it's July 22nd, 2022. Lots of twos today. Two is a good number. And I am joined by Dr. Harry Lever. Good morning, Harry.
Hi.
And we are here for another episode of Tales from the Heart, a podcast from the Hypertrophic Cardiomyopathy Association. Today, I have an announcement that I'm going to start with. And if you're a part of our Facebook group, this is being televised from the Facebook page, there's going to be a call to action. I only have a couple of days on this one. We are going to be working with the FDA on a project to evaluate the effectiveness of risk evaluation and mitigation systems, REMS programs. This is partially, we're doing this because of the REMS programs that are connected with the Camzyos launch of mavacamten. So Camzyos, mavacamten, same drug. And this is not an evaluation of Camzyos and its effectiveness in hypertrophic cardiomyopathy. This is more of a systems question. So if you have been prescribed, not part of a clinical trial, if you've been prescribed Camzyos and you have signed up for the REMS program, we would like to hear your experience. We're only looking for about 5 people. So if you are interested, please email Julie Russo at julie@4hcm.org, and Julie will help get your information, and then we can have a discussion about what exactly it is the FDA is looking for, and then get this all aligned for you. HCMA will be making its own comments about the REMS program system from our point of view, but this is an opportunity to speak directly with the FDA to share your experience to help make these processes more effective in the future, protecting patient safety, as well as improving, the logistics of how systems like this work. So if you have been prescribed Camzyos and you would like to share your experience, again, it's julie@4hcm.org, and she will assist you. So that was my big announcement for the morning. And my second announcement for the morning is this is the last Tales from the Heart podcast that you will see from this studio, I'll call it. It's really my office. The HCMA will be moving its offices next Tuesday. We will not be broadcasting next Friday due to a lot of moving stuff going on. So we'll be back with you the first week of August with our new studio and a new look. And it may not be completely ready yet, but we're going to try to be live and up to date by then. So that being said, it is July, and our theme of the month, we have 2 themes every month. Our first theme is Center of Excellence Care and why it matters. And our second theme is vacationing with HCM, what you need to know. I'm going to start with Center of Excellence Care. And we're talking with somebody who helped develop the concept of Center of Excellence Care, Dr. Harry Lever, with all of his years of experience at the Cleveland Clinic. So Harry, let's take a little journey back, because it's fun to look back sometimes. 1996, 7, we meet each other and I'm like, hey, I want to help patients with HCM. And you said, hey, I want to help patients with HCM. And we started working together all those years ago. At that point, what was the myectomy volume at Cleveland Clinic?
25 a year.
And what was your patient volume like at that point?
I don't absolutely remember that. I don't, that number, I was always struck by the difference in the myectomies, because I think within a year or so, we went from like 25 to 65 myectomies. I don't remember but certainly the numbers went up. There was no question that the number of HOCM patients in general went up. I mean, there was no question about it. And, you know, it was incredible.
So
in a time when we didn't have cell phones, you know.
No, we actually had to like call poor Karen, that poor secretary you used to have. I used to call her Karen, it's Lisa, I need Harry. Karen, it's Lisa, I need Harry. And then Karen and I became great friends. So back then, we had an understanding and appreciation for HCM based on the technology, the limited genetic knowledge. We were learning.
Right.
And from the time that your center was, you know, your destination surgical center always, but as things evolved, did your understanding of HCM evolve too? Oh,
there's no question about it. I mean, you'd see so much stuff that you would just learn as you went in terms of the anatomy, and that was the big deal, is that we would see different sizes and shapes, and you know, and that was just because we were seeing so many different patients that had such varying anatomy, and it was dramatic. The effects were dramatic, and that's how we started writing some papers. And you know, we were one of the first centers to recognize that there was a difference between elderly hypertrophic cardiomyopathy and the young type. Bernadine Healy and I worked together, and we recognized that there was a difference between what occurred in older people and what occurred in younger people, and that was a big deal, you know. And so, and again, it was just a matter of looking at, having the opportunity to look at so many different people.
So anatomies varied, symptomology varies, risk varies,
right?
Psychosocial implications vary. There's just so much that affects an HCM patient. And if you're only seeing a small number of HCM patients, you're not seeing the whole disease, are you?
Nope, not at all.
So back then, I started working with you and a few other centers to ensure that patients who had HCM could get to people who knew the disease at a deeper level.
Right.
And that became the model for additional programs to be added over the years. We now have 45 programs. We have a few more in process. By fall, we should add 1 or 2 more to the system. And then additionally after that. So why do you feel it is important for an HCM patient to be seen at a high volume center of excellence for hypertrophic cardiomyopathy?
Well, just because the people you're going to see are going to had more experience than somebody that sees 5 or 6 cases a year. And that it's just so important that you need to be able to, you know, it's like a car mechanic, you know, you want somebody that knows how to fix a lot of cars and isn't just, you know, that's the way it is. You know, you have to have people that are experts, or you need a good airplane. It's like an airplane pilot, you know, you want somebody that's got lots of hours flying jet
that kind of plane, right?
That's right. That's right. You know, and that's, you know, as a matter of fact, you know, airplane pilots, they have to test out on whatever plane they're going to be flying, you know, if it's a, you know, what, you know, so.
It's kind of hard to test out a doctor on that one.
That's
the other
right.
thing I want to talk about is the team and the access to other professionals who can be additive to the knowledge and understanding of that patient's journey and what options might be available for that individual patient.
Right.
Specifically, you know, in the case of Cleveland Clinic, you guys are a little spoiled. You got somebody named Nick Madeira in your surgery suite.
Right.
So you've got a very high volume, very well-respected surgeon. But there's other people on the team. There's interventional cardiologists. There's electrophysiologists. And then within electrophysiology, there are people who specialize in atrial fibrillation, sudden death management, lead extractions, device placement, and all of the sub areas related to HCM, but all working together, not against each other.
Right.
And I don't mean against each other like it's some plot against the patient, but if you're seeing an independent electrophysiologist or an independent interventional cardiologist or an independent, general cardiologist, they're working in silos. When you're in a center, you're working as a team. And I like when centers can fight nicely together and really push their point, what they think is right for a patient. And that passion is there for the understanding of the disease. You don't get that in low volume centers. You get that in a center of excellence.
Right.
Okay. So in your time in a center, are there any points in time or experiences that you felt that shifted the patient care dynamic? Is it the guidelines? Is it the fact that patients are coming educated and knowing what a center of excellence can offer? How do you think patients interact with centers?
Well, I think it's a matter of, you're you were able to direct people in the right places. That was the big deal, is that you knew enough about the disease that you recognized the fact that people needed to have skills to deal with patients like that. And it was a matter of working together. There was no, the only vested interest we had was taking good care of people. And there was no, it wasn't a matter of making money. It wasn't, it was a matter of taking good care of people. And people knew that they could trust, first they could trust you. And that was a big deal. I mean, you still have to be able to trust the people that you're dealing with. And that, there was no vested interest in our part. It was a matter of just getting the people taken care of. And that was a big deal.
It's funny when you start looking back. Every time I take a change, like 2014, we moved into this office. 2022, we're moving to a larger office. I take a look back, like I'm moving to a bigger space because we literally don't have any room here anymore. Like I've outgrown my office. And I think, where did this start? And how did I collect all this stuff? And where did it come from? And it really came from partnerships and caring, passionate physicians in the care of those with HCM. And it really came about because we all started working together collectively in the best interest of the patient. And that's really what this is about. And my why, we all have our whys. My family had been hurt enough by HCM.
Right.
And my sister died because of mismanagement. She was diagnosed. We got there, but she was mismanaged. And we still see mismanagement today, unfortunately, in low volume centers where people don't have a great deal of experience, or just a lack of appreciation from community cardiologists or community healthcare workers about HCM. So we're working to fix that problem. And we have a number of methods in place to do that. But nothing has been as impactful in this entire journey than the partnering with high quality medical centers and staff that understand the need for high volume care and truly working with the patient in ways that just don't seem to happen in regular clinical practice today. It takes time. It takes hours of conversation and testing and assessment to find the right treatment path for the right patient. And you can only do that when you have hundreds of patients that you've already worked with and you've learned along the way. What else can we say about centers of excellence and why they're important?
I think that's the biggest, biggest deal. And I think the fact that you have to have a good surgeon is clearly that. I can remember a case that I saw, well, somewhere a couple of years before the pandemic. Patient had been having a lot of chest pain, and he got to see a cardiologist somewhere who was an expert in putting in stents. And he, by the time I got to see him, he had had 10 stents without exaggeration. And problem was he wasn't feeling any better. And unfortunately, they hadn't recognized the fact that he also had hypertrophic cardiomyopathy. And they got stuck on the stents and didn't look past it. And by the time we saw him, the guy was in dire straits. And you just can't. That we were lucky we saved him. I mean, it was so bad, and so we ended up operating on him and doing a myectomy and also putting in some bypasses. Because the stents hadn't, and obviously they hadn't done what they needed to do, and plus they were technically a problem. So you gotta know, and when it comes to doing a myectomy, you gotta know how to do it in terms of don't take out too much, not take out too little. Understand now that we've kind of a big understanding about the mitral valve, that you can have obstruction to the blood flow out of the heart without having necessarily that thickened a heart, but you can still get obstruction, and you may have to do something to the mitral valve to make it, change the leaflets, change the papillary muscles, and that's a big deal. And if you don't know that, you may end up going to see a second surgeon for something to be done to the heart. You gotta know all those things, how do the papillary muscles work? How do the mitral leaflets work? And
I think, you bring up a point that I think there's a forgotten part of the heart. And I think it's the papillary muscles.
oh, yeah.
And I think they, most people don't even realize that they have these little finger-like apparatus at the base of their ventricle that's attached to the chordae, that's attached to the valve, and that they all work in concert, and that in HCM, they're commonly abnormal. They're too thick, they're in the wrong position, they've got double heads, they've got all kinds of weird things that can happen to them. I guess my favorite word for an HCM heart is they're a little wonky, but they work okay most of the time, but not perfectly. So it's pretty amazing that they work as well as they do with so many minor abnormalities to the anatomy. But when you go to a center of excellence, they're thinking, are the papillary muscles driving something here? And when you're in a traditional cardiology office, I don't know that they get the appreciation that they need to get, because they are a big driver of potential symptoms. Additionally, what you're saying about a patient who reports chest pain and they go, well, you must have some coronary artery disease. And I think if you went in and you looked at everybody over the age of 45, 50 in America, you're going to find some plaque in those, arteries in the heart. And that might make people think, well, that must be the cause of your chest pain. And I too have seen many people been told, oh, well, you just have, a little coronary artery disease and you need a stent, and that's why you had chest pain and it doesn't resolve. And then you're committed to a device, these implantable devices, stents, for the rest of your life. And they're not doing anything to really help you feel better. So I would say if somebody needed to have multiple stents, but they're still not feeling better, that they probably want to check out with another cardiologist to see if they're really getting to the root cause of that chest pain. So while we're talking about chest pain and HCM and centers, can you explain some of the other causes of chest pain? Like, where else would it come from if not from the coronaries?
Well, it can happen because you have a significant obstruction to the blood flow, and the pressure gradient goes up, and there's a decreased ability to supply the heart with enough oxygen because of the obstruction. So that's a big problem. And as a matter of fact, going back to stents for a second, I have seen patients who have had their management of HOCM delayed, that is having a myectomy, because they had a stent put in before they saw us. And after you put that stent in, you have them on a type of blood thinner that you can't stop, because the stent could clog up in the short term while if you stop it to go into surgery. So that's why I always tell patients, we got to make sure that what's all going on here before we, if somebody tells you you need a stent, you better look a little deeper to see what's going on. And that's delayed people's. I've said it can delay surgery for 6 months.
So additionally, so chest pain can come from obstruction. What about microvascular disease?
Well, I don't know how important microvascular disease is when many of these, most patients with HOCM, not all, but most patients with HOCM have huge arteries, and it's not as much of a problem as we see in other types of patients. It can happen, but it's not that.
Can you explain to people what microvascular disease is?
It means that the arteries are small, and you can get little plaques that you can't really ordinarily see. They're so small that when you do that angiogram, you can't really see it. And so but again, that tends not to be as much of a problem in a patient who has thick walls, and then the arteries tend to get bigger because of that. But it can happen, but it's not usually as big of a deal. There's about a 20% incidence of coronary artery disease in people who have hypertrophic cardiomyopathy. So about 80% do not have it.
And it's the common path is not to have coronary disease.
That's right.
But some people are just going to have both.
But the pain can look just like what you have with somebody with bad coronary artery disease, and that's why you've got to be careful, and you got to rule everything out. And
so once the diagnosis of HCM has been made, the assessment of root cause of symptoms is best handled by a center of excellence.
And the other big deal that we have to worry about is aortic stenosis, because if you get aortic, let's suppose somebody thinks you have aortic stenosis, and they want to put in a new valve with a catheter. That can be a problem because you remove that valve in the cath lab, and all of a sudden the heart tends to collapse when you take that valve out and put a new one in, because the obstruction at the valvular level is gone, and all of a sudden you get bad SAM that you didn't recognize. And that's when you might have to do an emergency alcohol septal ablation. We've had a few cases like that. And so again, if you think there's valvular heart disease, valvular aortic valve disease, you've got to look and look at that aortic valve and make sure that there's not a potential for obstruction if you were to take that valve out. So that's a really important deal. I mean, we've you got to be really suspicious about that. And sometimes if the patient is in such a situation where you think they wouldn't tolerate surgery for HOCM or the aortic stenosis, and you want to do a septal myectomy and replace the valve with a catheter, maybe what you're going to need to do first is to do the alcohol ablation, so you don't get the obstruction in the heart, and then replace the valve after that alcohol ablation. So you've got to really be aware.
So knowing that there's not just an answer, but there's a right answer for somebody with HCM. If you have a known diagnosis of HCM, I don't think they would do TAVR typically in somebody with HCM. I know they've been done because they didn't realize it was HCM.
That's what I'm talking about.
Yeah.
Not recognizing it.
And you gotta, disease recognition is everything.
That's right. And that's why you got to have people that are experienced in dealing with it.
Absolutely. So we will be taking questions in a few moments. So I'm going to pivot for the final. Oops, we do have some questions here. So sorry. Can you talk about chest pain and non-obstructed HCM? What are the tests to determine the cause of the symptoms of non-obstructed HCM? So somebody who has, non-obstructed HCM and they're getting chest pain, they're very symptomatic. What's the root cause of their chest pain?
Well, you want to look and see if they have, again, first start with a stress test and see if you can induce obstruction. You also want to see if they drop their blood pressure. It may be because of the obstruction, or it may be because they do have underlying coronary artery disease. And if you start seeing a so you get a drop in blood pressure, you want to see if there's obstruction. And you also want to see, what their response to the stress is, and if they're, if you start seeing a drop in blood pressure and there's no obstruction, well, then you need to look at those coronary arteries with a cath, directly with a cath. I mean, I've also seen non-obstructors who have dropped their blood pressure with stress, and they didn't have, they had such bad hokum that they would drop their blood pressure. And that's a sign of a very sick heart, and you've got to really look those people over. I had a patient like that about 10 years ago who we put her on the treadmill, and she dropped her blood pressure 40 points and no obstruction. And I was really worried about it. She had a really thick heart. There was no obstruction. And something said to me, I'm worried about this drop in blood pressure. And about 2 weeks later, I got a call from the mom from an ambulance, because we decided, when we saw that drop in blood pressure, we decided the patient ought to have an ICD. And the reason the call was from the ambulance was the girl was in school, she was doing something, had a cardiac arrest, and the defibrillator went off and saved her life. And the interesting thing is, within the less than a year now, she's just had a heart transplant. That was 10 years ago. And the heart was, badly diseased, and she went on for a time, but then it was clear that she had to have a heart transplant. So we saved her life 10 years back. We put that defibrillator in, she survived for a while, and then we ended up with a heart transplant. So you got to look for those sorts of things.
So if a traditional community-based cardiologist, and this is data that I have from the American College of Cardiology, sees on average 2,000 patients a year. And of that, 1 in 250-ish will have HCM. So we're talking about 10 patients in an average practice. Well, that person is managing those 10 cases. So I think it's almost impossible to say, okay, Harry, think of only 10 patients. If you had 10 random patients walking in, what is the likelihood that any 2 of them would be the same?
Not great.
And you could have some obstructed, some non-obstructed, some with latent obstruction, some with end-stage disease, some with AFib, some who are at high risk of sudden death. You've got so many different opportunities, but you're only seeing 10 a year. You're not going to see every piece of it. You're not going to know to look.
Nope.
And that's why,
Nope.
in my experience, Center of Excellence Care, I swear, saved my life. Having people who knew and understood the disease as part of my care team got me safely to transplant. Only 5% of us go to transplant. It's not the common pathway. But you can get there safely, and you have a destination if you have somebody who understands the disease completely. For those who need myectomy and then management, for those who are non-obstructed and need management, there's so many different opportunities for good care. So I just encourage you so much to use them, use a center if we have one. And I know it's a little frustrating to some of you when we're talking about how great care can be at a center, and it's not exactly convenient for you to travel to one. We are working very hard here at the HCMA to build more programs, but they have to be quality programs. It's not just because a doctor says, hey, I want to see more HCM. They have to go through a very lengthy process, and there's education involved, and there's follow-up, and there's site visits, and there's interviews, and there's evaluation. There's a lot of steps to becoming a center of excellence. They're not all equal. Some of them have lower volume than others. Some of them are early in their experience, and some of them are very well developed, but they're critically important, and we are trying to get more. If we can't get the care to your region, we are working on, I'm going to put a pitch in here. We are working on a fund that we have called the Lorry Fund. Lorry was my sister, and it will provide micro grants for travel to HCM Center of Excellence Care, at least for an evaluation. or maybe for your surgery. Or if you're at a center that does not have a transplant program, the micro grants would be available to be evaluated for transplant as well in another center. We are raising money for this program right now. And as soon as we hit some threshold numbers where we can actually start giving out the grants, first you got to raise the money, then you can give the money away. So my birthday's in 2 weeks, and I am doing a Facebook fundraiser for my birthday. And in that fundraiser, a portion of those funds collected will go to the Lorry Fund. We are having a fundraiser in October here in New Jersey. All the proceeds from, well, not all of them, because we have to pay for overhead and stuff like that, but the majority of the funds collected in that fundraiser will go directly to the Lorry Fund as well. So we will have these funds available. We will open up a grant process probably in the fourth quarter where patients can apply to get funding for airplane tickets, train tickets, gas money, food on the road, a hotel room for the night. That's what we're going to be able to cover.
Now that we've got this problem with COVID, that becomes even more important because the airlines are doing a bad job of getting people where they need to go. And the last place you want to get stuck is in an airport where people are not wearing their masks. And that's where disease is passing. And, and you also need to know what kind of shape the patient is in before they travel.
Absolutely.
Is it safer to take that? Is it, you got to worry about taking that chance of getting on an airplane that may not take you and may delay you somewhere if you're somewhat unstable, versus having somebody drive you or having an ambulance take you, because it depends on the stability of the patient. This is something that we haven't really had to worry as much about in the past, although I'd occasionally have some patients where we'd have to transfer them with an air ambulance. But you need to know all these things, because the last place you want to get stuck is traveling to a center of excellence and getting stuck. This is something we hadn't really ever had to think that much about.
So we have a couple of comments, questions, and then we're going to talk about vacationing and travel. We just talked a little bit about travel there. In general, are non-obstructed patients more likely to progress into heart failure?
It was just, it depends. That's a hard thing to say.
It's a tough question. It's a good question, Ann. It's a good question, but it's a tough one to answer.
You got to watch those patients carefully, and some of them, yeah, they can progress, but not everybody does. And some of the non-obstructors really aren't in that bad a shape, but it requires close follow-up so that we've given a class to some physicians, and that's one of the things we've talked about. And it's not, it's a matter of looking at the patient. It's not.
So, Ann, I don't know what this means on your message, but it says anniversary follower. You have a little tag on that. So happy anniversary on following the HCMA, I guess. I've never seen that show up on somebody before. Helene had a myectomy in November of 2020, but she still feels very poorly. So what should somebody post myectomy do if they're not feeling well? Uh-oh.
Wait a second. Don't worry. That's a spam.
We'll just let that ring.
You've got to look carefully at the patient. Yeah, I know it is. Hold on, I'm just gonna. You got to look at the patient very carefully, and first start with an echo and see whether the myectomy was adequate. That's the most important thing to see. If it wasn't, then you may be stuck having a second myectomy.
So you want to look for residual gradient, and you want to look at diastolic function, right?
Right.
Is the heart contracting and relaxing well?
But usually the problem is that they haven't gotten the obstruction taken care of. That's usually the biggest problem.
So we know that low volume myectomy centers don't tend to take enough, or they don't do a deep enough or wide enough myectomy. Right. However, even in the best surgeon's hands, and I've seen this a few more times over the years, and I finally think I understand what's happening here, and I could be wrong on this one. This is at least a hypothesis moment. But once you've changed the internal geometry of the heart, and there was an obstruction in area 1, so now the heart is no longer impeded there. The heart doesn't beat up and down. It twists like a towel, like you're wringing out a towel. And maybe because now the geometry of the internal ventricle has changed,
Right.
those contact points and those obstruction points may have altered slightly. This probably is like 2 to 3% of the myectomy population. It's very rare, but I have seen it a couple of times.
Well, and it has to do a lot with the mitral valve and the papillary muscles.
Yeah, it's
And
that full interplay.
Right.
So, Helene, I would suggest that you get back to a center, get some new imaging done, get to the root of where your symptoms are, and if we can be of assistance, do call the office, and we'll see what we can do to help you out. Gary, no, it doesn't work that way. Are all HOCM patients with sigmoid profiles considered high risk?
No.
Yeah.
No. Those tend to be are the older age group patients with a sigmoid septum. But they're not necessarily at higher risk, but you got to be aware of what you're dealing with, and depends on, again, what you start with, what you're going to end up with, and you have to look at this. That's why they have to be looked at very carefully, and also in the operating room, we carefully look at the patient and make sure that make sure that there still isn't residual obstruction. It's very important that those patients be looked at for that also, where we might stimulate them with a drug called isoproterenol to see if we can induce obstruction and make sure that we've taken care of everything that we needed to take care of.
Fantastic. Okay, so let's pivot for a moment. We kind of started talking about this. And when we have a topic of the month and I have multiple people talk about it, I think it's great because we get different perspectives on the same topic. So traveling with HCM over the summer, I typically am thinking of normal times and non-COVID times. However, we're in COVID times and we're traveling. So I know there is no longer a federal mandate to travel in public transportation with masks. I personally think that's short-sighted, and we're seeing explosions again in COVID. Yes, we have people who are vaccinated, doubled, and boosted, so the impact of the disease is less. I had COVID in May. It was not fun, and thank God I was protected as much as I could be. But I actually didn't get it in travel. I got it at a local mall trying to do a social event. Live and learn, because masks came off for a little bit and there was a variant going around at that point, and boom, we got hit. And now we have other peaks. So wearing masks in public, number one, in crowded stores, probably still a really good idea, people. On planes, trains, Ubers, definitely a good idea, people. Wear your masks. I know it's not comfortable, but I was traveling with a mask way before the pandemic. I went coast to coast multiple times. It does not impede your ability to breathe. It maybe caused a little bit of redness around my nose for a couple of days, but that was the consequence of not breathing in that recycled air that has other people's whatever in it. So we want you to do the masks and the hand sanitizers and the wipes, and wipe down your seat and do all of those smart things. I've been doing something for years, the airflow above you on an airplane. I take an alcohol wipe and I wipe the actual nozzle so that the air coming down out of there might just be a little bit cleaner. These are some of the tips that I've picked up as a transplant patient. So I encourage you all to use all of those protections. Harry, what else do you think people need to know COVID-wise traveling?
There's a website from the CDC, cdc.gov, and it tells you by county what the incidence of the disease is. It comes out Thursday night at 8:00 every week. And like last night, it came out and the numbers are not looking good in lots of places. California, for instance, is almost all red. Florida is all red. New York, which had been very bad, is now looking almost all green. And, Massachusetts had gone up, and Vermont and all that, And now it's sort of passed there. So one of the things I think I would think about is, where do you think you're going to go and see what the incidents might be there, to try, not that that's going to absolutely prevent you from getting sick, but you would rather not go into a place that is graded severe when you could find another place that might be safer. And that website I check it every Thursday night. And what I saw in Ohio did not make me happy last night.
Mm.
And if you look at there's something wrong with your state though, in New Jersey.
New Jersey gets funny when you say that, but yeah.
It's gotten very red again. And I don't know what it is about that, but it's maybe, I don't know what the reason is, but
I think areas that have big airports and
yeah,
lots of people that work in the airports, and it's coming in from wherever, and then those people are going out to the community. So
maybe.
we have a lot of people from a lot of places coming through New Jersey as well.
Yeah. Well, maybe that's why Illinois is so red. Whereas right now, Michigan, believe it or not, had been really in some trouble. It too is not looking bad now.
Okay.
So you just that's something to think about, is where and you want to know also about where you're going. You want to know about the restaurants that you're going. Can you have a restaurant that you can eat outside, or do they have takeout service where you don't have to sit in a place where because when you eat, you got to take the mask off. And so if you would be better to take the food out and to wherever you're staying, in a hotel or something like that, that might be safer. These
So
are all
make wise accommodations to your travel and
right.
be COVID sensitive, because you don't want COVID on top of HCM if you can otherwise avoid it.
And if you can drive a car, you're probably safer than getting on an airplane now, because of that problem where they didn't think it was important to wear a mask all of a sudden. And we've got to start hoping that politicians will stop making medical decisions, because that's.
So we have a question regarding COVID. You've already had COVID and came through it okay, mild symptoms. Should you assume that you'll be fine if you get it again, or is that naive?
That's naive.
We don't know what the next strains are going to be,
No.
but the strains will continue to evolve. And, first, we didn't have any treatment. So we have treatments now, so that's a little bit better. But what you're seeing is it was harder to contract up front. And this virus is a smart little virus. It's making itself easier to attach to you. So it might have meant milder symptoms for this more transient variant, but we don't know if these variants will get stronger or they will just kind of peter out and fade away and come back in cycles like the flu. So we don't know yet. And I think it's naive to think, I had it in May. I was not happy for 10 days. It was not good, but I was not in a hospital. I don't want to try again. Thank you. But I think I know people who've had it 3 and 4 times now, and each one was a little bit different. Some were better, some were worse. But you got to be careful out there, people. You got to be careful. So let's pivot to HCM related vacation things to think about. And I always start with hydration, hydration, hydration. You're outdoors, it's hot, you're getting dehydrated, not great for HCM. You're at an amusement park, you're eating salty, fatty foods, and you're drinking and you're dehydrated. Is this a good thing for somebody with hypertrophic cardiomyopathy?
No, you need to drink electrolyte fluids. Fluids that contain a little bit of sodium, usually they're what we
So
say.
Gatorade, Propel.
Gatorade. Yeah, that kind of stuff is important. And you don't, now particularly these past few weeks where it's been so hot, you've got to really be careful, because people, you get dehydrated with this disease, you're in big trouble. And you've got to.
So why are they in big trouble if they're dehydrated?
Because
what's the mechanism?
The mechanism is that the cavity of the heart shrinks, if you have a tendency for provocable obstruction, you can develop it with the dehydration. And you've got to, really be careful about that. And you've got to, the hydration is so important. It is just, and at the same time, even people who don't have hypertrophic cardiomyopathy can get pretty sick if they really get dehydrated. When it suddenly goes to 100 degrees out there or more, that's a big problem. And
so we want to make sure they stay hydrated. We want to make sure that they don't overdo it. I'm a vacation overdoer. If I'm on vacation, I want to get every minute out of the day and I want to do a lot of stuff. And when I had HCM, if I did the amusement park thing, I got a scooter so I could do the scooter thing. So I wasn't exerting as much energy, so I could get more energy out of, do more things in the day. You have to limit your energy. You have to know what you're capable of doing. And that's knowing where your limits are and not being afraid to tell the family, okay, you guys go do that. I'm going to sit by the pool today and relax. You've got to balance. If you've got kids with HCM, vacation, they want to just go do. You want to make sure that you're scheduling some downtime. You want to not be running all the time because they're going to get exhausted. They're going to get dehydrated. They're going to not eat well, not rest well. So remember, vacation's supposed to be restful. Somehow in our lives, we kind of turn to the Disney station is the way I look at it. And we have to go someplace big and do big things. We should relax, people. Beaches, rivers, lakes. Go sit and look at water. Relax. We're running all year long. Our brains are constantly engaged. Put down the computer. Put down the phone. Relax. Best thing you can do for yourself. Okay.
I kind of jokingly told people some of the safest places to go, maybe like Alaska, where it's not real hot in the summer.
It's not.
No, and you just, rather than going down to southern Florida or someplace like that where.
Oh no, you go to Florida in the winter and then you go to Alaska in the summer. This is the way you keep yourselves at normal speed. So if you're traveling, remember, keep your medications with you on the plane or in the train. Make sure that you know where they are at all times. I did get a question the other day about a family who they have multiple family members with HCM and nobody has ICDs, but they have an AED in the house. Yes, you can take your AED with you on vacation. That's fine. You're probably not going to need it, but if it makes you feel more confident and comfortable with where you're going, then certainly bring your AED with you or call to see if the hotel has an AED on site and what their policies are related to AED placement. And maybe you want to choose your hotel based on whether or not they have such accommodations. And I think that's a wise idea. HCMA, when we were holding our in-person meetings, we would only have meetings at hotels that had AEDs on site. Since then, New Jersey passed a law and there's AEDs in every hotel now. So pretty safe coming to Jersey, but most people don't want to come to New Jersey on vacation. I don't know why. We have a great boardwalk. We have a fantastic mountain region with beautiful lakes, rivers. Come to Jersey. We're fun. So giving my Jersey pitch. I'm a Jersey girl. What can I say? So what else do people need to know about vacation?
I think that's
pretty much it.
Yeah, I think so. I mean, I tell you, not right now, Florida is not a good place to go. It's extremely hot. It is very high in COVID. And I don't think I would recommend going to Disney at this time. I mean, if you're talking about, you gotta, and sometimes going out to places in the countryside where there aren't as many people, the temperature's a little cooler. You just, but that's really important. I mean, I can't stress that enough. You want to be where there aren't as many people, and it's not real hot, and you can, but you also want to be sure that there is some medical facilities around so that, if you ran into trouble, you'd have somebody that and it might be worthwhile looking around just to see, is there a hospital? Because, they've been talking about Georgia, where the medical facilities aren't very good, it seems. So,
Really?
yeah,
So rural areas have small hospitals,
So-
if they have any at all anymore.
right,
A lot of
right,
them have closed.
right.
So you want to make sure you know where a hospital is. Even if it's
Exactly.
not a great hospital, they can transport you. They have the systems in place.
Right.
They can transport you elsewhere.
Right.
And I would also make sure that you have a copy of your recent EKG with you,
That's right.
because we have a propensity to freak people out in emergency rooms.
Right.
When they see our EKG, they're like, "Oh, it looks like you're having a heart attack." Can you tell
Right.
people why that is, Harry? Why do HCM people look like they're having a heart attack?
Because the EKGs they look like, they have increased voltage. They have the deep T wave inversion is what we can see with coronary artery disease. So that's why, you want to say, when you show up in the emergency room with a physician who doesn't have a lot of experience in that disease, it's helpful to be able to say to them, I've had this EKG before, and it's not, like for instance, if you needed some sort of emergency gastric surgery, something, that is
Unrelated.
unrelated, or you hurt yourself and you needed orthopedic surgery or something like that. You don't want that anesthesiologist to worry that maybe we shouldn't put you under anesthesia because the EKG is so markedly abnormal. And if you can say, "Oh, I've had this before," that's a big savings.
So many years ago, I was in a very minor car accident. It was leap year day, and it was a snowstorm in Jersey, and somebody crossed a double yellow line, bopped me into a corner, and when I hit, the ambulance came, they said, "Are you okay?" And my heart was racing because I'd just been in a little car accident. I'm like, I have a heart condition. Da, 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 da. And immediately I was off to the hospital. I'm like, I'm fine. It's not related to my heart, but they took me because I was in an accident.
Right.
So when I got to the emergency room, they came in with EKG leads. I said, "We're not doing that." And they're like, "It doesn't hurt." I'm like, "I'm well aware, but I'm not doing that because here's what's going to happen. You're going to see a right bundle branch block. You're going to freak out. You're going to see high voltage. You're going to see T wave abnormalities. You're going to think I'm having a heart attack. You're going to want to take me to the cath lab. I'm not going to the cath lab. And we're going to start this whole cascade of drama, and I'm not playing." And the nurse just looked at me like, "Okay, the doctor's going to come in and talk to you." So the doctor walked in and he's like, "Why won't you have an EKG?" I said, "Because I have hypertrophic cardiomyopathy, and you're going to freak out. You're going to think I'm having an MI. You're going to want to bring me to the cath lab, and I'm not going. I just got in a little car accident. Just make sure my neck's okay." And he looked at me and he said, "You're right. It will cause drama. We won't do the EKG." And the nurse was stunned because I wasn't there for that. And there was not going to be surgery, and there was nothing else. They would just make sure my neck's okay. And we moved on from there. So you sometimes have to advocate for yourself in weird places. So I do encourage you bringing an EKG. We do have two questions that are not related to the topic, but we have 2 or 3 more minutes. So I will address them together for Gary. Gary wants to know 2 things. What does it mean to have complete left ventricular cavity obliteration? And why is alcohol bad for hypertrophic cardiomyopathy?
Well, the second one first. Alcohol can induce atrial fibrillation, and the thicker the heart, the less alcohol you need to go into atrial fib. And I've for years told my patients to really stay away from alcohol. You don't want to take that chance. People who don't have hypertrophic cardiomyopathy, if they drink too much, can get atrial fibrillation just from the alcohol itself. It can act as almost like a poison in the heart. So certainly if you have hypertrophic cardiomyopathy, you want to stay away from alcohol. And what was the second question was?
What is cavity obliteration?
Cavity obliteration means just that. It means that the cavity can get very small, where there's almost no cavity at all. And that happens with thick hearts. That happens also with thick hearts that the patient is dehydrated. So we want to keep the patient well hydrated. That's why you don't want to get dehydrated on a hot day.
Fantastic. Gary, I encourage you to join our newly diagnosed discussion group. We hold it once a month. that might help answer some other questions about the anatomic presentations of HCM. You can get those discussion group listings on our, excuse me, on our website, and we hope you all join them. This is 2 months post-COVID. I still do this nasal congestion thing and I cough. I'm sorry. It's getting better though, slowly. So yeah, Connie carries a copy of her EKG, and that's great. All right. Well, we're down to another episode of Tales from the Heart in the vault. And I hope you've all enjoyed this conversation. And Gary and I have a call scheduled on Monday. Oh, yes. Okay. Yes. You're my only call on Monday because that's our last day in the office. Tuesday, we pack up and we move to 66 Ford Road, Suite 213B, where we will have a lovely office and an elevator, which I'm really excited about because we're a little nonprofit and we've never had a real suite with an office with an elevator before. We've traditionally been a walk up. So it's nice that we have a new facility that we're moving to and some room to grow. And I am hoping to make a couple other announcements in the middle of or beginning of August with some new programs and some new stuff happening. So stay tuned. There's always something percolating here at the HCMA. And a reminder to those who joined late, if you are taking Camzyos and you've scheduled prescription, like not the trial, but you actually have a prescription and you are in the REMS program, the FDA and HCMA are interested in hearing your experience with the REMS program. This isn't really about Camzyos and its utility. It's more about the systems in place and how you have interacted with them. Please email Julie at 4hcm.org, JULIE at the number 4hcm.org by Tuesday, because it's going to move very quickly. We're going to need to get this information over to our partners at the FDA, and they want to hear your experience. So I'm looking for 5 people. So here's your opportunity to change processes and explain what your experience was and maybe give some constructive criticism so that we can make better systems in the future. These opportunities do not happen often, people. So please take advantage of the opportunity to have your voice heard and make changes that might help other people. This is not just about HCM. It's about all REMS programs. So they're looking at MS drugs, oncology drugs, a couple of other classes. And I would love to have some representatives of the HCM community participating in this. So please email us. And Julie just popped in with her email. So Harry, thank you so much for your time today. As always, delightful to speak with you. And I'm going to sign off of Facebook now. So goodbye, Facebook.